Margaret Chen is 71 years old. She spent her career surrounded by books, helping children fall in love with reading, and now she cannot get through a single chapter without falling asleep in her chair. She wakes up dizzy most mornings. By noon, the room feels like it is tilting. By 2 in the afternoon, she is done. Not tired, done. The kind of exhaustion that sits in your bones and refuses to move. Her blood pressure numbers look perfect. Her doctor smiles at every visit. Her chart says she is doing well. But Margaret does not feel well. She feels like she is disappearing one slow afternoon at a time, and she has started to believe that this is simply what getting old feels like. Her daughter refuses to accept that. She pushes for a second opinion. A new doctor sits down, goes through Margaret's chart carefully, and does not change her diagnosis. He changes her medication. What he finds is not a new disease. It is not cancer. It is not heart failure. What he finds is that the medication Margaret has been taking faithfully every single morning for 6 years, the medication everyone told her was keeping her safe, has been quietly working against her in ways nobody bothered to explain. Within 3 weeks of the change, the dizziness lifts. The fog clears. She reads 2 full chapters in a single sitting and calls her daughter crying. "I feel like I got 2 years of my life back," she says. If you or someone you love takes Amlodipine, Losartan, or Lisinopril, what happened to Margaret may sound familiar, and what you are about to hear could genuinely change the conversation you have at your very next doctor's appointment. Here's the uncomfortable truth that most patients are never told. These 3 medications save lives. That is not in question. They are among the most prescribed drugs in the world for good reason. But the way they are prescribed, dosed, and monitored in adults over 65 is often dangerously incomplete. Side effects that are directly caused by these medications are being dismissed day after day in doctors' offices across the country, not out of malice, but because of a pattern of assumptions that nobody is stopping to question. Fatigue is being labeled as aging. Dizziness is being labeled as aging. Brain fog, swollen ankles, a cough that will not quit, a blood pressure reading that looks beautiful on paper but sends someone to the floor. All of it is being labeled as aging. And millions of people are accepting that answer because they trust their doctors and because nobody told them there was another explanation to consider. There are 6 things on this list. 6 critical pieces of information that most patients taking these medications were never given. You need to stay through all 6 because number 3 is a side effect that an estimated 15% of people taking one of these medications are living with right now, blaming it on everything except the actual cause. And number 5 involves a blood pressure reading that a room full of medical professionals called perfect, right before a woman ended up on the bathroom floor. Before the list, you need one framework, one way of thinking about everything that follows. It is called the dose assumption trap, and once you understand it, you will see it everywhere. Here is how it works. Your doctor prescribed your medication based on clinical guidelines. That is appropriate and responsible. But here's what most people do not realize. Those guidelines were built primarily on studies involving patients in their 50s and early 60s, not 78-year-olds, not people taking 4 other medications, not people whose kidneys are operating at 60% of what they were 20 years ago, whose liver processes drugs more slowly, whose cardiovascular system responds to medication differently than it did 2 decades ago. The second part of the trap is this. The dose that controls your blood pressure on paper may quietly be creating symptoms that you are attributing to age. Fatigue, dizziness, brain fog, and swollen ankles are not inevitable parts of getting older. They may be your medication, hiding in plain sight behind the word normal. And the third part is the one that keeps this trap locked shut. Controlled blood pressure on your medical chart does not automatically mean optimal blood pressure for your body. A number that looks perfect in your records might actually be making your daily life worse. And because the number looks fine, nobody asks. Nobody sits down and says, "How are you actually feeling? Can you stand up without getting dizzy? Are you sleeping? Can you get through a day with energy?" That is the dose assumption trap. The numbers look fine, so everyone assumes the medication is fine, and the person taking it keeps quietly suffering, while everyone around them nods at the chart. Keep that framework in mind through everything that follows. The first thing most patients are never told is that these 3 medications work in completely different ways inside the body, and that difference matters enormously. Robert Morales is 68 years old, a retired truck driver from San Antonio. When his blood pressure came back elevated during a routine physical, his doctor handed him a prescription for Amlodipine and said, "Take this once a day." Robert asked one question. "What does it do?" His doctor said, "It lowers your blood pressure." And that was the entire conversation. Robert took that pill every day for 2 years without understanding a single thing about how it worked inside him, why it had been chosen, or what warning signs he should be watching for. That lack of understanding nearly cost him. Here is what Robert was never told. Amlodipine is a calcium channel blocker. It works by relaxing the muscles in the walls of your blood vessels, allowing them to widen so that blood can move through with less resistance and less pressure. Losartan is an angiotensin receptor blocker, sometimes called an ARB. It works by blocking a specific hormone that sends the signal to your blood vessels to squeeze tighter. Lisinopril is an ACE inhibitor. It works one step earlier in that same process, preventing your body from producing the enzyme that creates that vessel-constricting hormone in the first place. 3 different medications, 3 completely different mechanisms. 3 different sets of side effects, drug interactions, and risks that become increasingly significant as the body ages. Knowing which category your medication belongs to is not a small detail. It determines what you need to monitor, what foods may interact with it, what symptoms you should never ignore, and whether the specific medication you're on is actually the right match for your particular body and health situation. So, here is the first question to bring to your next appointment. Why did you choose this specific medication for me instead of one of the other classes? If the answer is specific, your kidney function, your history, a medication interaction, a particular risk factor, that is a good sign. If the answer is vague, or if nobody seems to remember the reason, that conversation is worth having more deeply. And it is within those side effect profiles that things begin to get genuinely uncomfortable, especially with one of these 3 medications. The second thing most patients are never told involves a symptom that is being called harmless in offices everywhere, when it is anything but. Linda Hargrove is 73, a former postal worker from Richmond, Virginia. She has been on Amlodipine for 4 years. For most of those 4 years, her ankles have been swollen, not a little puffy, swollen enough that she cannot wear the shoes she wore throughout her entire adult life. She brought it up to her doctor twice. Both times the answer was the same. That is a common side effect. It is harmless. Do not worry about it. Linda trusted that answer. She bought wider shoes. She elevated her feet every evening. She adapted. She accepted it. Until one afternoon when the swelling became so severe that her daughter took her to urgent care, where they discovered that the edema had been masking a deeper circulatory problem that had been developing and going unmonitored for more than a year. This is not unusual. Research published in the Journal of the American Heart Association has documented that amlodipine-related peripheral edema affects up to 10% of patients, and that number increases significantly with age and with higher doses. In routine clinical practice, it is often minimized or dismissed, but the underlying mechanism makes it far more than cosmetic. Calcium channel blockers like amlodipine dilate the arteries, but they do not dilate the veins at the same rate. That imbalance causes fluid to leak from the small capillaries into the surrounding tissues. In younger patients, the body often compensates for this. In older adults, who already have reduced venous return and less efficient circulation, this creates a cascade of consequences. Swelling leads to reduced mobility leads to further circulatory decline. Further circulatory decline leads to an increased risk of falls. That is not harmless. That is a chain of events with serious consequences at the end of it. If you are experiencing swollen ankles while taking blood pressure medication, do not simply accept that it is normal and move on. Ask for a comprehensive medication review. Alternatives exist. Switching to an ARB, adjusting the dose, or combining lower doses of 2 different medication classes can often solve the problem without creating new ones. It's common and it's harmless are not the same thing, and you are allowed to expect more than adaptation as a treatment plan. But amlodipine is not the only medication with something to hide. If you are taking lisinopril, what comes next may sound painfully familiar. The third thing most patients are never told is the most commonly dismissed of all, and it affects somewhere between 10 and 15% of everyone taking an AC inhibitor, possibly more. James Whitfield is 69 years old, a retired electrician from Knoxville, Tennessee. 3 months after starting lisinopril, James developed a dry, persistent cough. Not a cold, not allergies. A tickle in the back of his throat that gradually became a cough that would not go away no matter what he tried. He saw a pulmonologist. He had a chest x-ray. He lost sleep worrying that it might be something serious, maybe even cancer. For 8 full months, not a single physician he encountered asked him one simple question. What medications are you currently taking? 8 months of worry, disrupted sleep, and unnecessary testing. The answer was sitting in his pharmacy records the entire time. ACE inhibitor-induced cough is one of the most well-documented side effects in all of cardiovascular medicine. The mechanism is understood clearly. Lisinopril blocks the enzyme that would normally break down a substance called bradykinin. When bradykinin accumulates in the respiratory system, it irritates the airway lining and triggers a persistent dry cough that no amount of cough syrup, no allergy medication, and no throat lozenge will touch, because it is not coming from an infection or irritation. It is coming from the medication. In older adults, this cough carries consequences beyond discomfort. It disrupts sleep, which then affects cognitive function, mood, and cardiovascular recovery overnight. Coughing fits can trigger dizziness and sudden drops in blood pressure, both of which increase fall risk. The constant physical effort of coughing strains chest muscles and can worsen shortness of breath in people who already have limited pulmonary reserve. And the psychological toll, The months of wondering, the fear, the unnecessary medical appointments is a cost that never appears on anyone's chart. The fix is straightforward. Switching from an AC inhibitor like Lisinopril to an ARB like Losartan eliminates this problem in the vast majority of patients, often within days. This is thoroughly documented. It is well understood by the medical community, and it is completely manageable. No one should ever be told to simply live with a cough that their medication is causing. If you developed a persistent dry cough after starting Lisinopril or any other AC inhibitor, and nobody has connected those two facts yet, that connection is worth making at your next appointment. Ask directly. The answer may end months of unnecessary suffering. Now, after everything just discussed, Losartan might sound like the obvious safer choice. And in some ways it is, but the fourth thing most patients are never told involves a danger, specific to both Losartan and Lisinopril, that is rarely monitored as carefully as it should be. This one does not need a patient story. The hospital data is more than enough. Both ARBs, like Losartan, and AC inhibitors, like Lisinopril, have a well-documented effect on potassium levels in the blood. They reduce the activity of a hormone called aldosterone, which is responsible for signaling the kidneys to eliminate excess potassium. Less aldosterone means less potassium leaves the body. Potassium builds up. And in older adults, this process can become dangerous more quickly and more silently than most people realize. Data published in the American Journal of Kidney Diseases shows that hospitalizations related to elevated potassium levels, a condition called hyperkalemia, among older adults taking these medication classes are not rare events. They are alarmingly common and continuing to rise year after year. Here is why older adults are especially vulnerable. Kidney function naturally declines with age. The kidneys become less efficient at filtering and removing excess potassium from the bloodstream, even without any medication involved. Add a drug that further reduces the body's natural potassium clearing signal, and you have a foundation for accumulation. Now consider what many health-conscious older adults are eating every day. Bananas, spinach, potatoes, sweet potatoes, avocados, beans. These are foods that appear on every heart-healthy eating list in existence. They are also extremely high in potassium. Add a potassium-containing supplement, or a salt substitute, that many people use to reduce sodium without realizing that most salt substitutes contain potassium chloride, and the accumulation can reach dangerous levels. The part that makes this particularly frightening is that hyperkalemia often presents with no symptoms at all. No warning, no signal, until it triggers a cardiac arrhythmia, an abnormal heart rhythm, that can be fatal without any preceding indication that anything was wrong. If you're taking Losartan, Lisinopril, or any medication in either the ARB or AC inhibitor class, your potassium levels and kidney function need to be checked regularly, at minimum, every 6 months. This is not a precaution for people with kidney disease. This is standard monitoring that every patient on these medications should be receiving, and that too many are not. At your next appointment, ask directly, when was my potassium last checked? If no one can give you a clear answer, that is a gap in your care that needs to close before you walk out of that office. But the fifth item on this list is the one that is perhaps the most counterintuitive of all. It is the one where the danger does not come from the medication failing. It comes from the medication working exactly as intended. Dorothy Flanagan is 76 years old, a retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was what her doctor called perfectly controlled, 118/70. At every visit, her doctor smiled and said the numbers looked great, and Dorothy smiled back. Her chart looked like a success story, but Dorothy was falling, twice in the kitchen, once in the driveway where she scraped both palms on the pavement catching herself, and then one Tuesday morning, her daughter found her on the bathroom floor. Dorothy had stood up from the toilet, the world went black, and she went down. The emergency room gave her a diagnosis, orthostatic hypotension. Every time Dorothy stood up, her blood pressure dropped sharply. Her brain was not receiving enough blood flow. The medication that was supposed to protect her heart was putting her bones and her brain directly at risk. The research on this is substantial and growing. Analysis of the landmark SPRINT trial, along with studies published in JAMA Internal Medicine, found that aggressive blood pressure, lowering in adults over 75, pushing systolic pressure below 120, was associated with significantly increased rates of falls, fainting episodes, acute kidney injury, and dangerous electrolyte disturbances. The American Academy of Family Physicians has formally recommended more relaxed blood pressure targets for older adults, suggesting that a systolic pressure below 150 may be more appropriate for many patients over 75 who are managing multiple health conditions. Think through what happens in that bathroom moment. The medication has lowered blood pressure aggressively. Dorothy stands up. Blood pools in her legs because her blood vessels cannot constrict fast enough to compensate for the sudden change in position. Her brain receives insufficient blood flow within seconds. The room dims. Her vision narrows. She reaches for the wall and misses. She falls. She fractures a hip. Surgery follows. A hospital stay follows the surgery. Hospital stays in older adults carry real risks: infections, blood clots, disorientation, medication errors. After the hospital comes weeks of immobility. Immobility leads to muscle loss, which leads to further fall risk, cognitive decline, depression, and loss of independence. All of it began with a blood pressure reading that everyone in the room thought was good news. What to do about this is concrete and specific. Ask your doctor to check your standing blood pressure, not just your seated blood pressure. This is called orthostatic vitals, and it takes less than 2 minutes to perform. Request it at every visit. Have an honest conversation about whether your current blood pressure target is appropriate for your specific age, your history of falls or dizziness, and your overall health picture. Because a systolic reading of 140 might be genuinely safer for you right now than 118. The best number is not always the lowest number. The best number is the one that lets you live your actual life. Which brings everything together into something concrete and actionable you can use immediately. The sixth thing is a set of 5 questions. Screenshot them, write them down, put them in your phone. Bring them to your next appointment. These 5 questions could change the way your blood pressure is managed from this day forward. The first question is, why am I on this specific medication and not another class? You deserve a specific answer, not it lowers blood pressure, not it's what we usually prescribe. A specific answer about why Amlodipine was chosen for you instead of Losartan, or why Lisinopril was chosen instead of an RB. The answer should be about your health, your history, your risk factors, your other medications. If it isn't, that is a conversation worth continuing. The second question is, what is my blood pressure when I'm standing up, not just when I'm sitting down? A reading taken only while you're seated in an exam chair gives you half the picture. The other half is what your blood pressure does when you stand, when you get out of bed in the morning, when you rise from a chair after sitting for an hour. That other half could be the difference between safety and a fall. The third question is, when were my potassium and kidney function last tested? If you are on an ACE inhibitor or an ARB, and you cannot get a clear answer to this question, that is a gap in your monitoring that needs to close. Ask when the last test was done. Ask when the next one is scheduled. Put it on your calendar. This is not optional monitoring. It is essential. The fourth question is my current blood pressure target appropriate for my age and overall health? The right target for a healthy 55-year-old is not automatically the right target for a 78-year-old managing 3 other health conditions. Asking this question opens a conversation that many physicians do not initiate on their own, but that every good physician will respect you for starting. The fifth question is, are any of my other medications or supplements interacting with this one? Blood pressure medications do not exist in a vacuum. NSAIDs, the anti-inflammatory pain relievers many older adults take regularly, can raise blood pressure and reduce the effectiveness of these medications. Certain antidepressants interact with them. Potassium supplements amplify the potassium-raising effects of ACE inhibitors and ARBs. Even some common over-the-counter cold and decongestant medications can interfere. Your doctor needs the complete picture. And if nobody has ever asked you to bring in a full list of everything you take, including vitamins and supplements, that conversation is overdue. Any physician who takes your health seriously will welcome these questions, will respect you for asking them. And if your doctor dismisses you for raising these concerns, that tells you something important about whether that relationship is truly serving you. Come back to Margaret Chen for a moment, the woman who thought she was just getting old. Her new doctor did not find a hidden disease. He did not discover something that had been missed in her diagnosis. What he found was that the dose she had been taking for 6 years was no longer appropriate for the body she had now. He lowered it. He switched her medication class. He matched her treatment to who she actually was at 71, rather than continuing a prescription written for a version of her from years earlier. Within 3 weeks, the dizziness was gone. The afternoon exhaustion lifted. She read 2 chapters without stopping. She called her daughter and cried, "I feel like I got 2 years of my life back." Her blood pressure is still well controlled, but now the number on the chart and the life she is actually living finally match each other. That is the goal. Not just a good number. A good life. This is what needs to be said clearly, directly, and without softening. A blood pressure pill should help you live better, not just live longer. If your medication is controlling a number on a chart, but quietly taking your energy, your balance, your mental clarity, and your confidence along with it, that is not treatment. That is a trade-off you never agreed to, and you have every right to question it. The fatigue that arrived after your prescription did is worth mentioning. The cough that showed up 3 months later is worth investigating. The swollen ankles that change the shoes you can wear are worth more than a dismissal. The dizziness you feel every time you stand is a symptom that deserves a real evaluation, not a nod, and a note that says age-related. You are not required to accept declining quality of life as the price of managed blood pressure numbers. These medications exist to help you, and if the way they are currently being prescribed, dosed, or monitored is not actually helping you, if you feel worse on them than you believe you should, you are entitled to say so, to ask questions, and to expect answers that are specific to your life and your body. The 5 questions exist for exactly this reason. Not to challenge your doctor's expertise, not to refuse medication, but to participate in your own care in the way that every patient has a right to. The best blood pressure is not the lowest possible number. The best blood pressure is the one that keeps you safe and lets you live fully. Those 2 things should not be in conflict. And in many cases, with the right monitoring and the right conversation, they do not have to be. If you take any blood pressure medication, or if someone you love does, and something in what you just heard resonated, share this. Not because a video needs views, but because Margaret Chen's story is playing out in living rooms and kitchens and doctors' waiting rooms every single day, and most of those people have not yet heard that there is another explanation for how they feel. Most of them are still telling themselves they are just getting old. They deserve to know that might not be the whole story,